Buenas tardes, señoras y señores. Me llamo Bernard Cholley y soy de París. Muchas gracias al doctor Hans García Araque por su invitación. Soy muy feliz de participar a esta videoconferencia. Voy a hablar en inglés porque yo hablo poco español. So excuse me, but I will continue with English. During the next few minutes, I will talk to you about fluid management, and I will quickly browse some physiological aspects and some practical issues. First of all, if you think of hemodynamics, most often we've learned hemodynamics with the cardiologist. And the cardiologist told us that the left ventricle produces the cardiac output under the influence of 4 major parameters, which are preload, afterload, contractility, and heart rate. But in reality, this is not reflecting what happens, because in reality, each of our organs, the muscles, the brain, the splanchnic system, or the kidneys, the liver, they all request a certain amount of blood depending on their activity and their oxygen consumption. And the venous blood leaving these organs returns to the right ventricle, which pumps the blood that returns to it towards the left ventricle, which in turn ejects the cardiac output. So looking at this, you see that the important aspect is the venous return and not necessarily the left ventricle itself. Of course, in reality, unless you are having a congenital heart disease with a shunt, your venous return and your cardiac output should be the same at all times. So if we are interested in understanding hemodynamics from the venous return point of view, it's relevant for us to look at the determinants of venous return. And for that, we will look at the Poiseuille's law. Poiseuille was a French physiologist that lived in the 19th century. And in fact, he lived just after Ohms, the Danish physician who described the relation between the intensity of a direct current in a circuit that is proportional to the voltage at the edges of the circuit and inversely proportional to the resistance of the circuit. So Poiseuille said, okay, it's roughly the same for the flow through hydraulic circuit, and the flow itself is proportional to the pressure gradient between the entrance and the exit of the circuit, and is inversely proportional to the resistance of the circuit itself, which means for venous return that the flow is proportional to the pressure gradient between the entrance of the vein, and this is mean systemic pressure. I will come back a little later to explain that, versus right atrial pressure, which is the pressure at the other end of the venous circuit. And the flow of venous return is inversely proportional to the resistance of the veins themselves. So on this equation, we've got the 3 determinants of venous return: mean systemic pressure, right atrial pressure, and resistance of the veins. I will start with the right atrial pressure, which is probably the most familiar to all of us. The right atrium is where all the venous blood converges. And therefore, the pressure inside the right atrium is the force that opposes venous return. And indeed, if you look at the equation, the greater the right atrial pressure, the smaller the numerator, the smaller the venous return. But we usually consider right atrial pressure as the right ventricular preload, and we all have this curve in mind, meaning that, okay, if we increase right atrial pressure, we will increase stroke volume and cardiac output. But in reality, I just said the opposite. There is an apparent contradiction, and in a few minutes, I will try to reconcile this. Normally, if our right ventricle is normal, if our heart is normal, we maintain right atrial pressure as low as possible. And normally, the value of the right atrial pressure in a normal heart is close to 0. Of course, we see many patients who have a greater value of right atrial pressure, but these patients are sick. They have IV lines putting fluids in them, they are ventilated, they have a sick heart. But if you have a normal heart, physiologically, your right atrial pressure should be as low as possible to facilitate venous return to the right heart. If you observe an increase in right atrial pressure, it must be accompanied by a similar increase in the driving pressure, the mean systemic pressure, if you want the venous pressure to remain, the venous return to remain unchanged. So the mean systemic pressure is the name of the average pressure at the beginning of the veins, representing the driving pressure for venous return. And if you see this mean systemic pressure, the greater the mean systemic pressure, the greater the numerator, the greater the venous return. But in reality, we don't use this because it is very hard to quantify, because venous pressures are highly variable according to the location within the body. If you have a man standing in front of you, if the value in the right atrium is close to 0, the pressure in the vein of the feet is close to 100 millimeters of mercury because of the weight of the column of blood above it. But conversely, the pressure in the sinuses of the head is negative. So what is the average pressure at the beginning of the veins? The American physiologist Arthur Guyton designed the experiment that allowed the estimation of the mean systemic pressure. And he said, okay, if I elevate the right atrial pressure to the same level as the mean systemic pressure, cardiac output should stop because the numerator of the Poiseuille's equation becomes 0. And in a quite complex experiment in dogs that were deprived of reflexes, he was able to construct this venous return curve, showing that with 0 in the right atrium, venous return was maximum. Because when the pressure goes below 0 in the right atrium, then you have a collapse of the right atrium or the vena cavae. And you cannot increase venous return further. But when you increase the right atrial pressure, you observe a decrease, a linear decrease in venous return, and this venous return becomes 0 for a value of mean systemic pressure that is only 7 millimeters of mercury. So that means that in a dog that is anesthetized and deprived of reflexes, the driving force for the venous return is only 7 millimeters of mercury, which is incredibly low. Finally, the last determinants of the Poiseuille equation, the resistance to venous return. Of course, the resistance of the veins is very small in comparison to systemic vascular resistance. But because the pressure gradient is so small, even teeny variations in resistance to venous return can greatly modify venous return and cardiac output. So maybe you said, he's crazy. What is he talking about, the resistance of the veins? But in fact, you do change the resistance of the veins of your patient each time you give them fluids. Indeed, a flat vein has a very high resistance, but when you fill it up with fluids and it becomes cylindrical, the resistance becomes very low. On the other hand, if the vein is completely collapsed, the resistance is infinite and the flow is 0. If you look at the Arthur-Guyton venous return curve, the resistance is represented by the inverse of the slope. If you reduce the resistance, the slope is greater and the venous return is greater. If you increase the resistance, the slope is less and the venous return is less. So finally, if we represent the cardiovascular function curve and the venous return curve on the same graph, we can see that they intersect at a single point, which correspond at a single and unique value of similar cardiac output and venous return, which correspond to a single value of right atrial pressure. And this is where I reconcile my apparent contradiction of the beginning. You can see that right atrial pressure is indeed the preload of the right heart that determines the performance of the heart ejection, and at the same time is the forces that opposes venous return. So now, if we want to look at these determinants and see where they play their role on the venous reservoir, we have to imagine the veins as a bucket like this. The bucket that is not fixed in volume. In fact, you can change the capacitance of the veins. You can vasodilate or you can vasoconstrict and change the size of the reservoir. You can see that the exit of the reservoir is not on the bottom, it's on the side. And the height here of the faucet representing the exit corresponds to right atrial pressure. The lower the right atrial pressure, the easier for the liquid to leave the reservoir and to return to the right heart. The amount of liquid that fills up the reservoir below the level of the exit is called the unstressed volume. It represents the amount of blood that fills up your circulatory system without generating any distending pressure. And on top of that, you've got the stressed volume. And the height of the liquid in the reservoir represents the mean systemic pressure. And you can see that what will determine the force that pushes the liquid to leave the reservoir is the hydrostatic pressure between mean systemic pressure and right atrial pressure. The size of this little tube here represents the resistance of the vein. Now, we have to realize that everything that we do in our daily practice is affecting these determinants of venous return. When we give fluids to a patient, we add more liquid in the venous reservoir, which will result in a greater mean systemic pressure, which will increase venous return and increase cardiac output. We all give fluids to our patient every day, but are we looking at cardiac output when we give fluids to our patients? But in fact, the primary effect of giving fluid to someone is to increase venous return and cardiac output. On the other hand, if we give diuretics to a patient, or if we use hemofiltration during dialysis, we are withdrawing liquid from the reservoir, which will eventually reduce the height of liquid in the reservoir, which might reduce venous return and cardiac output. Now, if we play with vasodilators or vasoconstrictors, you can see that vasoconstrictors like norepinephrine or ephedrine, phenylephrine, they will constrict the arterioles, but they will also constrict the veins. And by constricting the veins, they will shift some unstressed volume into stressed volume, and therefore they will increase venous return and cardiac output. We give vasoconstrictors very often to our patients. I'm sure that you all check the variations in mean arterial pressure, but are you looking at what happens on cardiac output? Because usually the first injection of vasoconstrictors has a major effect on cardiac output. And the reverse is also true when we use vasodilators, like, for example, anesthetic agents. And finally, even the use of inotropes can be viewed from the venous return point of view. If you give dobutamine to a patient, and if you assume that dobutamine improves contractility without changing anything else to the cardiovascular system, which is of course a little simplified, but by helping the heart to contract, you will help to reduce the congestion in the right atrium, and you will decrease the value of right atrial pressure. And by reducing the right atrial pressure, you increase the gradient, you increase venous return, you improve cardiac output. In fact, I just want to emphasize the fact that we very often talk about the volemia of our patients, but we are unable to quantify volemia. We are also unable to quantify the capacitance of the veins, but we can easily quantify stroke volume or cardiac output, which results from the interaction between volemia and the venous capacitance. We use fluid therapy on a daily basis because our primary aim as anesthesiologists is to maintain or restore tissue perfusion in our patients. At the level of you've got capillaries under the tongue of a patient that is hypovolemic. And you see that the flow in the capillaries is very slow, sluggish, that barely move. Whereas in this view, after fluids, the same patient, the flow is very everywhere. It's maybe not very clear on your screen, but every capillary moves very fast. When I try to improve tissue perfusion in my patient, I try to change the perfusion from what it looked like in the upper left quadrant into what it looks like in the lower right quadrant. And not only under the tongue, of course, but also in the brain, in the kidney, in the liver of my patient, wherever it's important. So I use fluids for that, but fluids have two main side effects. If I do not give enough fluids, I might have low flow and hypoperfusion in my patients. But if I give too much fluids, I can generate congestion and edema. If I am dealing with a low-risk patient, a patient that is ASA1 or ASA2, if I represent here the ideal fluid load that I have to give to my patient, if I am able to achieve the ideal fluid, I reduce the perioperative morbidity risk as much as I can. And if I move away, because it is a low-risk patient, if I do not give enough fluid, or if I give too much fluid, I slightly increase the risk in my patient, but almost nothing. But if I am dealing with a high-risk patient, the picture is completely different. It is extremely important to achieve the ideal fluid load, because if I move away, if I do not give enough fluid, this patient is at risk of developing complications because of the low flow and the hypoperfusion of certain organs. The organs that are the most at risk in that specific patient, which of course may vary according to the patient. Sometimes it's the brain, sometimes it's the heart, sometimes it's the kidney. I might have organ dysfunction or even organ failure if the problem is too severe. But on the other hand, if I give too much fluids, I will generate congestion and edema. And congestion and edema are also responsible for a decrease in tissue perfusion, because edema is water that accumulates and increases the distance between the capillaries and the mitochondria of the cells. And by increasing this distance, I reduce the diffusion of oxygen to my cells, and I am reducing the perfusion of my organs. So it is very important to keep in mind that in high-risk patients, fluid is potentially a dangerous medication. I have to remember that if this is a circulatory system with the right ventricle ejecting in the lungs, the blood from the lungs returning to the left ventricle ejecting in the aorta, the arterioles, the capillaries, and here my venous reservoir, and the blood from the venous reservoir returning to the right heart. If I give fluids to my patients, the primary effect is to increase venous return and increase cardiac output. So if I go back to my cardiovascular function curve, each of us normally functions in the preload dependent part of the cardiovascular function curve. If we receive fluids and we move from A to B, we will observe a nice increase in stroke volume, a large delta. But if we repeat the same fluid challenge, exactly the same amount from B to C, the increase in stroke volume will be less because of the shape of the cardiovascular function curve. And at some point, we will reach the plateau. And if we keep on giving fluids, we will not increase stroke volume, we will not improve tissue perfusion, but we will start generating congestion and edema. Therefore, it is extremely important to check stroke volume when we give fluid to make sure that they are useful, that they increase stroke volume, and to stop them whenever we reach the plateau. This is an example in a patient in which we started with the value of stroke volume measured here with esophageal Doppler, but you have many tools to measure stroke volume. And we gave 200 mL of gelatin, and you see that stroke volume went from 58 to 105 mL. And this is in 3 minutes, time to administrate the fluid challenge. An 80% increase in stroke volume. At the same time, the mean arterial pressure changed a little bit, but not much. But the stroke volume increased by 80%, which is huge. So we repeated the challenge with another 200 mL of gelatin, and this time, stroke volume increased only by 15%. Again, this is normal. The second fluid challenge has less effect than the previous one because we are getting closer to the plateau of the cardiovascular function curve. And finally, the last 100 mL that remain in the vial, you see that did not change stroke volume at all. So we've reached the maximum value, which means that I have to stop my fluid infusions in that patient, not just slow it down. I have to stop because all the liquid that I will provide to my patient after this will not increase stroke volume anymore and will generate congestion. I will keep on monitoring the stroke volume, and if it decreases again further during the surgery, I will try to give a little more fluids. But if the stroke volume is maintained at the same value, I will not change anything. This was an example in a single patient. This is a group of patients in whom you can see that if we divide the first vial that we administrate just after anesthesia induction into 2 parts, you can, and if you measure stroke volume in response to the first half of the vial and the second half, you can build the cardiovascular function curve of each patient. And also, all these patients were just before cardiac surgery. They were a homogeneous group of patients somehow. They are very different. Some are very bad with a very low stroke volume that does not increase very much with volume. Some respond very well to the first challenge, but not to the second. Some respond to both. The conclusion of that is that you cannot have a rule that applies to every patient, especially high-risk patient, because they are all different. You cannot believe that one size fits all. If you want to achieve the best administration of fluids in your patient, you have to titrate and to measure stroke volume in each high-risk patient. This is the only way to make sure that your fluid administration is producing the effect that you are expecting. And this is the only way to stop giving fluids when you've reached the plateau of the cardiovascular function curve. Studies that have tested this strategy as opposed to the fluid administration without any special monitoring are many in the literature. They have been meta-analyzed, and this is quite a long time ago now. And in this meta-analysis, there was already a reduction in the hospital length of stay in this study, very significant. There was an earlier return to oral diet after digestive surgery, and there was a risk of having postoperative morbidity or complications that was strikingly reduced. More recently, there was this very nice trial published in the British Journal of Anesthesia, the FEDORA trial, which was a multi-center randomized controlled trial involving 450 moderate risk surgical patients that excluded ASA4. In fact, I wonder why, because these are probably the ones that would benefit the most from this procedure. All underwent major surgery, and they were dispatched between two groups: those who had a traditional fluid management, meaning, empiric fluid management, and those who had fluid titration guided using stroke volume measurement. And there was much less complication in the stroke volume guided group, 8.6% versus 16.6%, a very significant difference. So the French Society of Anesthesiology recommends, on the basis of the evidence in the literature, to use a strategy of stroke volume measurement associated with fluid titration to achieve the maximum value of stroke volume and to stop giving fluids when the maximum is obtained. So if you give a first bolus, if you don't have an increase in stroke volume, stop fluids. But if you have an increase that is more than 10%, you can give a new bolus until you reach again the lack of increase in stroke volume and you stop fluids. If you observe a decrease in your stroke volume that is greater than 10%, after a while, you can start a new bolus again. So, in conclusion, every therapeutic intervention that we do in our daily practice, fluids, but also giving medication that reduce the volemia, like using diuretics, or giving vasoconstrictors or vasodilators, giving inotropes, all these interventions affect venous return and modify stroke volume. Very importantly, because it's probably the thing that we do the most often, fluid administration can lead to complication when insufficient or in excess. And it is now well demonstrated that stroke volume guided fluid titration is safe, suffers no limitation, and has been associated with improved outcome in high-risk surgical patients. And with this, I thank you for your attention.